There's the opportunity to deliver drugs post-transplant as maintenance therapy that reduce the risk of disease recurrence. There's two broad groups of agents that one can think of: disease-specific drugs such as FLT3 inhibitors, and there's promising retrospective data using sorafenib, reported by the Massachusetts General Hospital, where they showed that patients who had, for whatever reason, received sorafenib post-transplant had a much lower relapse rate compared with historical controls, but a randomized prospective study is required, and that's now launched and recruiting, looking at post-transplant gilteritinib maintenance, led by Mark Levis. The other interesting observation recently reported in that setting is that sorafenib in murine models seems to result in upregulated expression of IL-15, which accelerates donor T cell reconstitution and may plausibly augment a graft versus leukemia effect. So these putatively targeted therapies may actually be having pleiotropic activities which augment a graft versus tumor effect. And then the other broad group is epigenetic therapies, and there's some interesting phase 1-2 data with azacitidine and decitabine, showing not only does it upregulate a T cell response to tumor antigens, which otherwise you normally don't see post-transplant, but also that it's well tolerated, and a randomized study comparing maintenance with an oral version of azacitidine CC486 is about to be launched.